And the first one is in diabetic neuropathy, did microvascular dysfunction injury Schwann cells? Anyone in the panel that can answer that question?
Maybe I could add that the pictures that I showed of microvascular injury and where the degree of symptoms, early symptoms correlated with basement membrane damage is studied by Giannini. They only studied endoneural vessels there, but of course there is also injury to the Schwann cells, and particularly the aldose reductase injury, if you will, is one that's localized there. But it's clearly something that needs to be studied a lot more, what the cellular localization is of that injury.
Thank you very much. There's another question here. I don't know if this is one for you, David. You talked only about NAV 1.7. The role of NAV 1.9 and 1.8, is that relevant also for painful diabetic neuropathy?
I'm sure it may well.
Yeah, I think it's fine.
I'm sure it may well be relevant. I kind of gave 1.7 as an example. 1.8, NAV 1.8 and 1.9 are again voltage-gated sodium channels. They're expressed predominantly in nociceptors and they're TTX resistant. So they've got a very good pedigree in pain biology, and actually Catherine Faber and Giuseppe Lauria and Steve Waxman have shown in certain small fibre neuropathies, for instance, and actually in some other rare Mendelian pain disorders, you can see mutations in these ion channels. Plus, as Trolls mentioned, that you can get post-translational modification of 1.8 in the context of diabetic neuropathy. So I would absolutely agree that 1.8 and 1.9 probably do have a role in diabetic neuropathy.
Thank you very much. There's a question here. How long does lidocaine have an effect on painful diabetic neuropathy? I don't have the answer to that, but the study from 1987 showed that it could last up to 8 days. And I think it would be very interesting to do a new study and really see if this is something that is true, that there might be some central effect here. Yes, there's a question there, please.
Yeah, coming back to the question of vascular perfusion, you have an excessive vessels in the retina and kidney in diabetes. What's seen in the skin before it gets to the point of an overt breakdown of the tissue? Leading up to that process, what's the skin vasculature look like?
I don't
press it. Yeah.
Actually, I don't know, but the issue of your raising of, why would hypoxia not cause, angioproliferation like it does in the eye is a very interesting one, because it would be a normal response to tissue hypoxia. So clearly that's something that would be very interesting to see in peripheral nerves and in skin. What we hypothesize is that, of course, you could fix this by generating all new capillaries, but the problem is that the formation of new vessels, like in the eye, would actually create new shunts for oxygenated blood, so actually tend to make hypoxia worse.
Right. That's what I would imagine, is that you're creating more vessel, but you're not putting more blood through it.
Exactly.
So it sits there, and you extract more oxygen out of it. So it's a counterproductive mechanism to why you normally have it in developmental biology. Developmental biology, it's useful to grow vessels. In this case, it isn't.
Exactly, and we were actually trying to look for what is the break that inhibits that angioproliferation. Thank you.
Thank you very much. I think it's time to close this session here. I would really like to thank the audience here for coming, for asking wonderful questions. I'd like to thank the panel. So without the three panelists here, this would not have been possible. So thank you very much indeed.